I'm one of the providers in the Duke Memory Disorders Clinic, and I'm going to be speaking to you today on anxiety and depression in dementia. So like I said, I'm going to be speaking on anxiety and depression in dementia with a focus on Lewy body dementia. I just want to add that I'm recording this lecture. I'm very grateful that Dementia Alliance is putting on this conference in honor of Dan Coffer and his dedication to Lewy body dementia and frontotemporal lobar dementia. Also, very grateful for my colleagues at UNC that are continuing to practice on in his memory. So unfortunately, I have a meeting for the Duke UNC Alzheimer's Disease Center at the same time, and we'll also be giving a presentation at that meeting too. So very sorry that I can't be with you here today, but also glad that the caregiver conference is taking place, and applaud Dementia Alliance for organizing this conference for patients and caregivers and also other providers of dementia and memory care. This is an overview of my talk. I'm going to be describing the neuropsychiatric symptoms associated with dementia or cognitive and functional loss. Also talking about the prevalence of depression and anxiety to specific neuropsychiatric symptoms in dementia, how to identify depression and anxiety, and then how to possibly treat depression and anxiety. So when we think about neuropsychiatric symptoms, these are symptoms that are associated with the changes in the brain that are occurring with neurodegeneration or cell loss. And there are several symptoms. They all involve a change in thoughts, feelings, behaviors, and depression, anxiety leads the list. So also people can experience apathy or loss of motivation or interest, disinhibition, which is more inappropriate social behaviors that people normally wouldn't engage in, psychosis, which involves delusions or hallucinations, agitation with verbal or physical aggression, or excessive motor activity such as pacing or inability to stay still, sleep changes, and appetite and eating problems. In 2017, the Lancet Commission, which is a group of dementia specialists from the world, got together and established key messages for dementia care. How can we prevent, intervene, and care for patients and caregivers with dementia? And one of the things that they identified is one of the things that I bolded, which is to manage neuropsychiatric symptoms. Neuropsychiatric symptoms have a huge burden on patients and caregivers. They can cause a lot of distress, and it's very important to figure out how to best manage neuropsychiatric symptoms for quality of life. We also know that there are a fair amount of sequelae or consequences of neuropsychiatric symptoms in dementia. When patients and caregivers are living with neuropsychiatric symptoms, there can be significant distress and poor quality of life for both parties involved. There's also worse self-reported quality of life scores for patients. The more severe the neuropsychiatric symptom, the lower the survival rate of the patient over a 3-year period, and the earlier patients are placed in an institution or nursing home. We also know that neuropsychiatric symptoms overall increase the cost of dementia care and create healthcare costs for patients, families, and for society as a whole. Neuropsychiatric symptoms are very prevalent. This was a study done in Cache County, Utah by some of my Duke colleagues that showed that 97% of patients with dementia will experience at least one neuropsychiatric symptom over a 5-year period. And it's interesting to note that the most common neuropsychiatric symptoms are depression, anxiety, and apathy. There are other studies that have been done that show that all patients with dementia will have at least one symptom, and that it's interesting because symptoms can often co-occur with each other and increase their impact, such as depression and anxiety occurring together. And then somebody could also have depression, anxiety, and sleep and wandering symptoms. And you can see that when more of these symptoms compile together, they can have more distress for patients and caregivers and quality of life. This is a study that I wanted to present to you that I was involved in looking at Medicare claims in North and South Carolina. So this is unpublished data at this point. It's still being written up by me for a paper, but I wanted to include it because it's of interest since we are dealing with specifically dementia in North Carolina. What we do know looking at this study is that anxiety and depression are very prevalent in patients with dementia in North and South Carolina. So out of all patients in the year of 2017 that had a Medicare claim for a dementia diagnosis, which is about 124,000 of them, we see that in North Carolina, about 35% of those patients had anxiety, and about 39% of patients with dementia had depression. It's interesting to note that women had higher rates of anxiety and depression than men. Women had rates almost about 40% in both, and men's rates were more about 30%. And then white individuals were diagnosed with anxiety and depression more often than Black individuals. So this study also showed that neuropsychiatric symptoms occur together. So of patients with anxiety, depression, and psychosis, if we look at patients who had anxiety disorders, about 60% of them also had depression, a little under 60%, and about a little over 60% of them also had psychosis. So these symptoms are all co-occurring together. Specifically with depression, about 63% also had a diagnosis of anxiety, and about 60% also had a diagnosis of psychosis. And then when we look down at psychosis, psychosis is less often associated with anxiety, depression at about 24% for anxiety, 22% for depression, than anxiety and depression together. Specifically, when we talk about Lewy body dementia, neuropsychiatric symptoms are part of the diagnostic criteria for Lewy body dementia. So I would say that in other dementias, neuropsychiatric symptoms, specifically in Alzheimer's disease, can co-occur with the cognitive illness, but in Lewy body dementia, they're part of the diagnostic criteria. So we know that to diagnose Lewy body dementia, these are the revised criteria that were developed in 2017. There must be a progressive decline of cognition and functioning, and also 3 core features, including fluctuating cognition, recurrent visual hallucinations, REM sleep behavior disorder, which I'll talk about more later as that relates to anxiety, depression, and then Parkinsonism. Supportive clinical features are many, but definitely include apathy, anxiety, and depression, the 3 most common neuropsychiatric symptoms involved with dementia. Wanted to include some information about how neuropsychiatric symptoms in Alzheimer's disease compare with neuropsychiatric symptoms in Lewy body dementia. And we do know that patients with Lewy body dementia are affected more severely. They have more neuropsychiatric symptoms, comorbid illness, frailty, functional impairment. All is more frequent and more severe in Lewy body dementia than in Alzheimer's disease. They're also more prone to a dependent state and a worse prognosis overall through the course of their illness. It's interesting to note that up to 1/4 of patients in the early stages of Lewy body dementia, sometimes before the disease is even diagnosed, can present with anxiety or depression as the first symptom. This is a study done in 2020, looking specifically at the first 5 years after a diagnosis of Alzheimer's disease or Lewy body dementia. and looked at, in this column, 111 patients with Alzheimer's disease and 85 patients with Lewy body disease, and confirms what I told you on the previous slide, that patients with Lewy body dementia in the first 5 years have more impairment in the basic activities of daily living, such as bathing, dressing, showering, doing things to take care of themselves, and also have higher levels of neuropsychiatric symptoms as demonstrated on the Neuropsychiatric Inventory Scale in the first 5 years after a diagnosis. This study in particular wanted to look at neuropsychiatric symptoms over time in Alzheimer's disease and Lewy body dementia. They followed people over a 12-year period from their diagnosis through 12 years later. And at the end of the 12 years, found that the Alzheimer's group had a shorter duration of symptoms overall, in that 3 groups of symptoms, including aberrant motor behavior, aggression, agitation, delusions, and irritability, were more stable in the Alzheimer's groups. And then these symptoms were also more fluctuating in the Lewy body group. 57% of patients with Alzheimer's disease and 84% of patients with Lewy body disease had recurring psychotic symptoms. So patients with Alzheimer's disease are, less patients with Alzheimer's disease are having recurrent psychotic symptoms than patients with Lewy body dementia, which is just confirms what we know about the differences in these illnesses. So the conclusion of some of these research studies that have been done to assess the differences in how neuropsychiatric symptoms present in Alzheimer's disease versus Lewy body dementia just confirmed that we need more research on these topics. So I think that a lot of research in neuropsychiatric symptoms with Lewy body dementia is just starting to be done and refined. And if we know more about how neuropsychiatric symptoms present differently, we could think more about potential interventions for controlling the symptoms and also helping patients and caregivers understand what they're experiencing, improving their education and also their expectations of what can be done to treat these symptoms and how these symptoms will affect their functioning in the long term. Moving on to identifying depression and anxiety. These are criteria for identifying depression, specifically in Alzheimer's disease. We know how to identify depression in a population with normal cognition, but identifying depression in patients with Alzheimer's disease was slightly changed in order to be more sensitive to patients who are experiencing depression. So patients with Alzheimer's disease do have to meet criteria for dementia, and then they only have to have 3 of the symptoms of depression instead of 5 for patients with normal cognition. So on this scale, criteria were added to detect the presence of irritability, social isolation, and withdrawal, which is often experienced by patients with dementia. And then criteria were also amended to account for a decreased positive affect or pleasure in response to social contact and usual activities that's experienced in patients with dementia as opposed to patients with normal cognition. Wanted to talk a little bit about the difference between depression and apathy. So when patients come in with their caregivers to talk about neuropsychiatric symptoms, I always try and make the distinction between depression and apathy. And that's partly because we treat depression differently than we treat apathy, and then it helps caregivers understand more about what's going on with their loved one. So often caregivers will say that their loved one doesn't have any interest in activities, just wants to sit and watch TV, has changed, is very indifferent about topics, and totally seems to have a personality change. And it's good to figure out, like, is that patient depressed or is that patient apathetic? And is the caregiver perceiving the symptoms as depression and that the patient has a lack of interest, and or is the patient truly experiencing a down or negative mood? So apathy is listed on the top line as a lack of interest, motivation, and emotion, but depression is very similar. So these two are difficult to tell the difference between. Depression is also a lack of interest, lack of motivation, but there's, in addition to the lack of interest and motivation, a negative mood, such as sadness, feelings of guilt, self-criticism, helplessness, or hopelessness. This was a research study that tried to look at patients with dementia who were experiencing apathy and depression or both, and figure out how to differentiate the two. And I think, on the left-hand column, symptoms of apathy include blunted emotional response, diminished interest, indifference. Sometimes patients with apathy can have suicidal ideation just related to lack of interest in living, whereas patients who are exhibiting depression can have a lot of self-criticism, pessimism, guilt. But when they're experiencing both symptoms, they can have low social engagement, sometimes fatigue, diminished initiation in activities, and hopelessness. Patients with dementia can become depressed as a result of decrease in their mental capacity that they're experiencing with dementia and the decrease in functioning. And this is basically due to the biologic changes in the brain that are occurring due to the neurodegenerative process or cell death. I like to refer to it in the clinic as, the brain is totally changing. Cells are dying that used to be there. And of course, people who might have interest in certain things, their interest might change as their brain changes. So patients with dementia can also develop apathy, sleep impairment, and social withdrawal that mimics depression and is interpreted as a depression by caregivers, but are not actually depression. So we do know that apathy and dementia affect different areas of the brain and have different neurotransmitters involved with them. Apathy is more of a frontal brain region problem and a problem with a cholinergic deficit or a decrease in acetylcholinesterase, whereas depression is more of a decrease in serotonin and then an imbalance between dopamine and norepinephrine in also the frontal area, but also the subcortical areas of the brain. So I like to think of more about depression as an imbalance in neurotransmitter function, and apathy as a disconnection in neurotransmitter input. This study looked at the distinction between depression and apathy, and also found that the distinction is difficult and that patients don't give much insight into what's going on, because often when they have depression or dementia, they often have difficulty or lack of insight into their mood or mental ability. So it's very difficult for patients to communicate what they're experiencing. So again, the distinction between depression and apathy may be clinically important. And that's because when we give drugs for depression, such as the serotonergic agents or agents that increase serotonin in the brain, that might help the depression, but the increase in serotonin in patients with can also increase apathy and withdrawal from engagement with activities. And then likewise, the drugs given for apathy, the dopaminergic agents, might relieve the apathy, but aren't effective as antidepressants. So just wanted to talk a little bit about the biology of depression in Alzheimer's disease versus Lewy body dementia. We are learning more about this due to autopsy studies that have been done on brains of people who've passed away from these diseases. And the autopsy studies do confirm the changes in specific neurotransmitters. So in Alzheimer's disease, autopsy studies show a decrease in serotonin and norepinephrine levels in the subcortical, cortical, and also hippocampal or medial temporal lobe regions. In Lewy body dementia, the autopsy studies show higher levels of alpha-synuclein, which is a protein involved with Lewy body dementia, in the substantia nigra. And basically, I think this is an interesting conclusion, is that depression in Lewy body is thought to be mainly related to dopamine. And so maybe the alpha-synuclein pathology in the brain is causing a decrease in dopamine. And so dopamine might be a more prominent neurotransmitter decrease in Lewy body dementia than it is in Alzheimer's dementia. So therefore, targeting the dopaminergic pathways in the brain might lead to a better potential treatment for patients with Lewy body dementia. We think about anxiety and dementia. There are also revised criteria for diagnosing anxiety specifically in patients for dementia. And this includes excessive anxiety and worry that's difficult to control with at least 3 of the following symptoms, including restlessness, irritability, muscle tension, excessive fears, and respiratory distress. So one thing about anxiety is that patients who are not experiencing anxiety can also have an overlap of symptoms that we see with anxiety, such as fatigue, difficulty concentrating, and sleep disturbance. So again, there is a fine distinction between these symptoms, and it is sometimes difficult to distinguish between anxiety and other neuropsychiatric symptoms of dementia that are occurring in isolation, such as irritability, aggression, wandering, and sleep disturbance. This is a study that showed that there is a large overlap between depression and anxiety, which was confirmed and that I told you about in that study that we did looking at patients with dementia in North and South Carolina. So this study found that between 68% and 75% of people with dementia have depression and anxiety symptoms both at the same time. So it's interesting to note that in their study, the anxiety was often not persistent and often related to situations. It was alleviated or reduced by care interventions by a caregiver, whereas depression was pretty much persistent all the time and not as easy to alleviate by caregivers. Again, depression involved sad facial features, self-blame, hopelessness, whereas anxiety involved being very hypervigilant, action-oriented, less despair than depression, and a lot of worry about the future. We do know that anxiety has a huge effect on cognition and dementia, and I often tell patients that anxiety causes cognitive decline because patients are trying to function at levels that they used to function previously, but then cognitive decline, I have that backwards. Cognitive decline can cause anxiety because patients are trying to function at levels that they were functioning at previously, but then anxiety can exacerbate cognitive decline because it's harder to think when anxiety is present. So it creates this big loop. So, my job is to try and figure out how can we interrupt that loop to help patients feel better in their daily lives and also function better. So we do know from several research studies that when patients have mild cognitive impairment and anxiety, that they can actually have more trouble with activities of daily living and seem like they're having a faster progression. They have more agitation, depression, sleep disorders, and decreased executive function compared to patients who don't have anxiety. And then also patients who have anxiety and dementia can have worsening cognition with decreased verbal learning and memory, decreased attention and concentration, and decreased executive function. Specifically in Lewy body dementia, a new study in 2020 showed that anxiety can be present more in the very early phases of Lewy body dementia than compared to Alzheimer's disease. This study showed that patients with mild cognitive impairment due to Lewy body dementia have more anxiety than patients with Alzheimer's disease and mild cognitive impairment. And also that patients with Lewy body dementia were 7.4 times more likely than patients with normal cognition to have a history of anxiety. So sometimes it's thought that perhaps anxiety itself could be a presenting symptom in the very early phases of Lewy body dementia. This is an interesting case study of a woman who was started having panic attacks at age 78, but then was diagnosed with Lewy body dementia sometime after age 83. So panic attacks were actually her first symptom that she was experiencing, then was experiencing some autonomic dysfunction and fluctuation in awareness about a year later, but started experiencing cognitive decline, was misdiagnosed as having Alzheimer's disease, then started having Parkinsonism and was misdiagnosed as having Parkinson's disease, and then started developing functional decline and then visual hallucinations about 5 years after the panic attacks, which resulted in a hospitalization, and then was finally diagnosed with Lewy body dementia. So this is an interesting trajectory that is also confirmed by other studies that may show that patients with Lewy body dementia do have more severe, earlier anxiety than patients with Alzheimer's disease. And then specifically in this study in 2020, the researchers wanted to ask the question, is anxiety different in patients with Alzheimer's disease versus Lewy body dementia? And the answer is definitely yes. So anxiety, as you can expect, they found in the results was more frequent in Lewy body dementia compared to Alzheimer's disease, and also was occurring up to 4 to 5 years before the diagnosis of Lewy body dementia was made, co-occurring with depression and living at home. So it's interesting to note that they found that patients were often experiencing intermittent panic attacks and that the symptoms were sometimes severe enough to require medical treatment. Overall, the patients in the study who had Alzheimer's disease had milder symptoms of anxiety, and the anxiety was often related with their coping and acceptance of having cognitive dysfunction, or like I said before, the anxiety that's associated with cognitive decline and trying to function as usual when cognition is decreased. So 2 other studies looked at the association of anxiety with REM sleep behavior disorder. And we know that often REM sleep behavior disorder can be present sometimes as much as 10 to 20 years before symptoms of Lewy body present. So this study confirmed that anxiety was associated with REM sleep behavior disorder, and as many as 15 to 23% of patients with REM sleep behavior had anxiety at the same time. So overall, studies showed that anxiety and REM sleep behavior is often present before the diagnosis of Lewy body dementia is made. I'm going to move on now to the treatment of anxiety and depression. So I will say that overall studies show that traditional treatments for anxiety and depression that are used in patients with normal cognition or patients who are of younger ages often are ineffective in Alzheimer's disease and Lewy body dementia. What studies have shown is that the cholinesterase inhibitors, or the cognitive medications that are given to treat these diseases, may have an effect on anxiety and depression. And that's shown in this study in Alzheimer's disease, which is a summary of many studies done on cholinesterase inhibitors, donepezil, rivastigmine, and galantamine, which show that these medications do have some impact on neuropsychiatric and functional outcomes. So specifically, there was a 1.72 point increase on a scale of neuropsychiatric symptoms. There was also modest improvement on scales of functioning and significant benefits for depression or dysphoria, anxiety, and apathy and indifference. So these medications, donepezil, rivastigmine, galantamine, when patients do have a diagnosis of Alzheimer's disease, try and get them on these medications, and there may be some effect on anxiety and depressive symptoms. In Lewy body dementia, we also know the same thing, which is confirmed in several studies, showing that specifically donepezil at the 10 milligram dose has effects on anxiety, apathy, and depression. So this study showed that delusions, hallucinations, and cognitive fluctuation improved with donepezil in all treatment groups, but worsened in the group that received the placebo. And then scores for hallucinations and cognitive fluctuation, also for delusions, hallucinations, apathy, and depression, improved on the 10 milligram dose as opposed to placebo. So the conclusion of the study was that the 10 milligram dose as opposed to the 5 milligram dose had more effect on improvement in hallucinations and cognitive fluctuation. Likewise, rivastigmine also shows a benefit in placebo-controlled trials at the 6 to 12 milligrams daily dose in being effective for apathy, anxiety, as well as delusions and hallucinations. Memantine, which is another medication that is not a cholinesterase inhibitor, did have an effect on cognition and improved those symptoms in patients with Lewy body dementia, but had no effect on neuropsychiatric symptoms. So overall, as I mentioned, with Lewy body dementia, there are no to few studies on the specific management of depression and anxiety. So we treat depression and anxiety with Lewy body dementia the same way we treat it in the population, mostly with selective serotonin reuptake inhibitors like sertraline, escitalopram, citalopram, the selective norepinephrine reuptake inhibitors like venlafaxine, also mirtazapine are preferred treatments that we use. Definitely avoid tricyclic antidepressants, which can have an anticholinergic effect, and that would be medications like amitriptyline and nortriptyline, which can actively worsen cognition and hallucinations and delusions in patients with Lewy body dementia. This is an algorithm for treating depression that was published by the Lancet Commission, which is a group of experts who came together to give recommendations on dementia treatment. And basically, I think, there's a lot of small print on this slide, but the main conclusion of depression treatment is that medication therapy should be considered last, and mostly for more severe presentations of dementia. So there always has to be a risk-benefit discussion with the patient and caregiver, because medications to treat depression can cause side effects. And there are other medications like getting patients involved in social activities, increasing communication with caregivers, also checking in with caregivers to see if caregivers are distressed or overburdened by the patient's symptoms, and then explaining the symptoms of depression and giving indicators for what needs to be treated, what doesn't need to be treated, and then a better understanding of the symptoms. So if medications are not effective after 4 to 6 months, it's recommended that recommended to discuss risk-benefit and then change or withdraw the antidepressant after reassessing. But if patients seem to be improving with their mood on an antidepressant, then it's good to continue the medication and reassess after about 6 months. So this leads me to the next topic, which this is a summary of evidence-based treatment in mental health, showing what I just mentioned before, that antidepressants overall do not show a significant improvement in depressive symptoms in patients with dementia and are known to lead to an increase in side effects. So there are very few studies showing effectiveness of antidepressants. However, when patients are depressed and experiencing a lot of distress due to their symptoms, we do continue to treat depression with selective serotonin reuptake inhibitors as a first-line treatment. But it is important to develop realistic expectations about how much of the symptoms are able to be treated or how much improvement is expected. So I do often explain that, with a neurodegenerative disease, there are changes that are taking place in the brain that are very difficult to treat with medication, just due to the nature of the illness itself. So as I mentioned, these are some research studies and reviews of antidepressant treatment, which does give further evidence that the clinical effectiveness of antidepressants is equivocal and weak. So specifically, there is some evidence for sertraline. There were two studies. A smaller study showed it was effective, and then a larger study did not find that sertraline was superior to placebo. This study in 2011 also showed that mirtazapine was no better than placebo treatment over a period of 13 and 39 weeks. Psychological therapies have been shown to be effective in certain situations, specifically cognitive behavioral therapy, interpersonal therapy, and counseling compared to treatment as usual can slightly reduce depressive symptoms. I will say that psychological therapies can be most effective for patients with mild cognitive impairment or mild dementia. Once people start to enter a moderate dementia stage, it's very difficult to conduct any of the psychological therapies just due to the nature of cognitive decline. Wanted to talk a little bit about the treatment for apathy. Especially if there's an overlap in apathy with depression. So this trial was done on Alzheimer's disease and methylphenidate up to 20 milligrams a day, or I think it was dosed at 10 milligrams twice a day. So there was no significant difference in a specific apathy evaluation scale, but there were differences noted in some apathy subscales. So there is some evidence that methylphenidate could be an effective treatment for apathy in Alzheimer's disease that was studied in this study. Some of the adverse effects of methylphenidate are related to its actions on the brain, which is increasing dopamine, and can cause hallucinations, delusions, or worsening of those symptoms, sometimes weight loss due to decreased appetite. Patients can sometimes experience an increased anxiety or joint aches. There were several reasons that patients dropped out of the study, including high blood pressure, feeling very nervous, having nausea, anxiety, or insomnia. Other treatments for apathy are, again, drugs that have an effect on dopamine, including amantadine, D-amphetamine, or modafinil, and they have shown mixed results. And this is thought to be due to the fact that the dopamine dysfunction in apathy and Alzheimer's disease might be driving the symptoms and be the cause. So this leads to the question, if depression is thought to be caused by a decrease in dopamine in Lewy body dementia, could these stimulants, methylphenidate, D-amphetamine, or modafinil or amantadine, be effective for treating depression in Lewy body dementia? So it'd be interesting to have more studies done in this area. Wanted to return back to this study that I did with some colleagues here at Duke, looking at anxiety and depression in the state of North Carolina and South Carolina in Medicare beneficiaries who have a diagnosis of dementia. And just one other thing we looked at as part of this study was their rate of prescribing anti-anxiety, antidepressant, and antipsychotic medications. And what we found was actually that rates of prescribing of these medications is quite high. So when we look at males and females, as we mentioned before, more females have a diagnosis of anxiety and depression, we can see in this column, and also more females are on medications for anxiety and depression. So, and there are high rates of patients on medications for anxiety disorders. About 45% of male patients are taking an anti-anxiety medication, 51% of female patients, and then for antidepressants, in patients with anxiety, about 72% of male patients, 78% of female patients are taking an antidepressant medication. It's interesting to note that antipsychotics are also being used in patients with a diagnosis of anxiety disorder at a rate of about 28% and 26%. So, and then likewise with depression, it sort of mirrors what we see with anxiety. Again, high rates of anti-anxiety medications, very high rates of antidepressant medications, and high rates of antipsychotic medications being prescribed to patients with the diagnosis of anxiety and depression. So the conclusions that we can say about this in the state of North and South Carolina is that overall, our study does show high rates of psychotropic medication prescribing in patients with dementia. So more than a third of patients are prescribed an anti-anxiety medication, more than 2/3 are prescribed an antidepressant, and more than 1/4 are prescribed an antipsychotic medication, specifically to treat depression and anxiety symptoms. So we do know that these medications from research studies are often ineffective at controlling symptoms and can have adverse side effects, which is a major concern, like a patient safety issue. So I think the most alarming is the high rate of anti-anxiety medication prescribing, including benzodiazepines that we see prescribed in our study. And this would be medications like alprazolam, lorazepam, and clonazepam. So overall, we know that benzodiazepines are not recommended in patients with a dementia diagnosis. They're considered unsafe in patients age 65 and over, and benzodiazepines are on a list called the Beers Criteria, which is a list of medications that should be avoided in general in patients 65 and over. And the reason why they can have adverse effects is that they can cause side effects, including increased confusion, sedation, increased falls risk, decreased balance, and decreased visual ability. So, and then in general, antipsychotic medications for anxiety and depression treatment are not recommended. This leads to a bigger issue, which has been confirmed in other research studies recently, showing there are high rates of potentially inappropriate prescribing for a variety of medications in the dementia population overall. So this would be dementia population that lives in the community and in nursing home settings. So it's just something to think about when prescribing these types of medications. Potentially inappropriate prescribed medications included sedatives and hypnotics like benzodiazepines that I listed, antidepressants, antipsychotics, and also anticholinergic medications. And the reason this is concerning is that potentially inappropriate prescribing can cause patient safety concerns. So when we think about treating depression and anxiety, I would say that prescribing these medications does involve a level of risk or harm. I like to refer to risk as harm versus benefit. And when talking with any patient and caregiver about whether we should prescribe these medications, I usually do bring up some form of risk versus benefit analysis and a discussion just to try and see, like, are the symptoms distressing? Are they meeting a threshold where medication is needed? And overall, just keeping in mind that the overall goal is quality of life. And so helping patients live their best life every day is very important to me in clinic. So how can we have patients live their best life every day with the way life is at this time? And sometimes that does involve prescribing these medications, and sometimes it involves trying to find other ways to deal with symptoms of anxiety or depression. So these are some of the list of select references that I referred to during the presentation that might be interesting to refer to for more details about anything that I've mentioned. And just want to end by talking briefly about the Duke UNC Alzheimer's Disease Research Center. I am involved with that center, as are several colleagues of mine that spoke to you today, and very excited about this new initiative in the state of North Carolina and this collaboration between Duke and UNC to further develop research to find causes and treatment of dementia. So just want to bring it to everybody's radar and let you know that we are a funded center at this point, and We do have a website if you have any questions about the center or getting involved in any research study going on at Duke or UNC in the field of dementia. So thank you so much for having me speak with you today. It's been very nice, and just hope you learned something about anxiety and depression and dementia. If anybody has questions, I'm sorry that I won't be able to be available for a question and answer, but I welcome any questions through the coordinators of Dementia Alliance or through emailing me. So thank you so much.
Okay, everybody, this is Lisa, and even though she said in her video that she would not be able to take questions, Dr. Johnson is going to join us any minute and try and answer some of those questions. We did want to take just a minute since she didn't really cover that in her talk, to speak a little bit more about non-pharmacological approaches to anxiety and depression with your loved one with dementia, any type of dementia at all. We want to make sure, that we are looking at the person's behaviors and trying to figure out, are they having a difficult, challenging, if you will, behavior as a result of being anxious or depressed, and look at some of the approaches that we have to our own depression to help a person living with dementia. So things like exercise, getting enough sleep, getting outside, getting fresh air, vitamin D, those kinds of things we know can help. And I am going to now bring in Dr. Johnson, and we're going to talk a little bit more with her. There we go. Give me just a minute. Hi.
Hi, how are you? Glad I could make it.
Yeah, thank you. We just switched over from your video, and we do have a few questions in our chat that I'd love to share with you. And then if you wanted to add anything, feel free. Couple of questions were, I guess the primary one was, are you familiar with any studies or anything that show that the long-term use of anti-anxiety meds or antidepressants increase the risk of dementia?
Oh, that's a great question. And I would say, let's talk about the anti-anxiety medications first. Those include the benzodiazepines, mentioned them, I think, in the recording. Actually, I did that recording yesterday, so my memory is not remembering the exact things that I mentioned, but I might have listed alprazolam, lorazepam, clonazepam as medications or anti-anxiety medications that a lot of people have concerns about with long-term use. We know that those medications do have an effect on the brain. They can cause cognitive slowing and changes in the EEG reading. Sorry, I wasn't not liking that background. I think I'll just put it on in my office.
That's okay.
Yeah, thanks. And so the studies are mixed. At first, there were some studies that showed that that there was increased risk of developing dementia in people who had been taking them long term. And now when we do studies of more people, actually finding that the risk might be lower than we thought. So that the risk of developing cognitive decline and dementia due to those medications may not be there as we thought it was, but there are other risks associated with those medications, including, just sedation when they're active and present in the brain, falls risk, and different risks for decreased coordination. So I think the risks also are a little bit dose dependent, with higher doses having more of an effect over time. So, and then with antidepressants, such as the selective serotonin reuptake inhibitors like sertraline, Prozac, Lexapro, citalopram, those type of medications, there's no evidence that shows that those medications over the long term can cause dementia or bring about any mild cognitive impairment. So actually, I think the research in patients with mild cognitive impairment shows that those medications can help delay progression from mild cognitive impairment to dementia.
Okay,
And then
that's really
depression
good to know.
and anxiety.
Great, thank you so much. I know when you and I had connected earlier, you said you had wanted to comment on something that was in your presentation.
Oh yeah, I thank you for reminding me. I
Uh-huh.
did want to comment on the section that I talked about with potentially inappropriate prescribing and just state that, it is, we do have to be very intentional about any medications, or my opinion is any medications that we prescribe to patients with dementia, and especially Lewy body dementia, just because I think that people's brains are very vulnerable. And so it is a good idea for medication safety and prescribing practices to look at, what types of medications we're giving people and always do a risk benefit ratio. So in some of the research that we've seen in North Carolina, and then that other people have done on potentially inappropriate prescribing in dementia patients, we found that we might be able to decrease the medications that we use in patients with dementia. But I also want to point out that in some instances, there could be patients that are really benefiting from medications that they receive, such as, antidepressants, in some instances, anti-anxiety medications. In general, benzodiazepines are not recommended for use in patients over 65, but there are always exceptions where somebody might react favorably to a benzodiazepine, always exceptions to other types of use of antipsychotics. So I think that it's really important to look at trends in prescribing, but also work with patients and families to help bring about outcomes for their life, for quality of life, and the best outcomes possible. So just wanted to comment on that and, make it known that, it's good to look at medications, risk, safety, balance, but it's also good to try them in some instances because they can have a benefit.
Great, thank you so much. We are getting actually a lot of questions on specific medications. And so I think that perhaps it's good to remind everyone to speak to their primary care doc or their neurologist or their psychiatrist, whoever they're seeing about those specific medications. But I will just mention a couple of those, and just if you have any random thoughts about them, Nuedexta is one of those.
Nuedexta is sometimes used for agitation in dementia. It doesn't have a any type of FDA label for that, but sometimes used for that. It's off-label use. I personally don't use it that much just because of side effects and mixed reviews on whether it's effective or not. I see in the chat, is there amphetamines? Wondering about that also.
Long-term use of amphetamines. It says for ADHD, so and risk of dementia.
Yeah, actually, I don't know anything about that either. I mean, I don't think that there's a lot of evidence for long-term use of amphetamines in association with dementia.
Okay, I have heard a lot of questions along the way, not necessarily today, about in general medications that are given either to children or adults for ADHD, not necessarily the amphetamines, possibly anything else. and the risk of increased dementia? So that's a question we hear quite a bit, actually.
Yeah, I guess I'd have to read more about that. So
Yeah.
don't know a lot about that in the older population.
Sure. And then one other medication question would be Seroquel and Depakote as medications given to those for people with dementia.
Yeah, so Seroquel and Depakote are used often, again, for behavioral symptoms related to dementia, a lot for agitation, and sometimes Seroquel for hallucinations, delusions, and hallucinations and delusions can cause agitation. So this combination is often used, can be helpful just because these medications sort of sedate and calm people. Seroquel is called quetiapine, or atypical antipsychotic, specifically in patients with Lewy body dementia. If I'm going to use an atypical antipsychotic, it's the one that I choose first. Actually, probably one of the safest ones to use in patients with Lewy body dementia. And Depakote is, or valproic acid, is a anticonvulsant, anti-seizure medication that just has some sedating properties and might be effective for agitation. So I think people with Lewy body dementia specifically tolerate Depakote pretty well. So overall, since there was an emphasis on Lewy body dementia, patients with Lewy body dementia are extra sensitive to a lot of things. You have to be careful about what types of psychotics are prescribed for patients with Lewy body, and then have to be careful if there's any type of anticholinergic properties in medications that can exacerbate cognitive or functional loss with Lewy body dementia.
Great. And then I guess we have just a couple minutes. Last question would be, you talked a lot about not using meds as our first course of treatment. So can you mention just a couple maybe of non-pharma ways that have been successful for your patients to work through anxiety, depression, or perhaps apathy? Have you heard anything that's worked especially well for your clients?
Yeah, I think one of the things that works the best for people is social engagement. So we're social animals. We're meant to be around other people, meant to talk with people, meant to see faces every day. And there's a lot of meaningful social engagement that can go on for people of all cognitive levels. And we know that, depression, people who are depressed often socially isolate, but a form of behavioral activation in depression is getting people, being around other people and talking with other people and interacting. Increased activity is very important as behavioral activation, like exercise and walking and just finding, I think when people do get depressed with cognitive decline, there can be some wondering, like, what is my life going to mean going forward? I don't want to be a burden to my family. And I do a lot of counseling and therapy, letting people know that, that as people, we're important to other people. So even if you have dementia and you might be changing, I mean, we're all changing, right? Every day we change as people. Every day, everything changes, plants change. And so all living things are changing. And with dementia, if you reframe dementia, even though it's not a favorable diagnosis as we know it, and nobody's asking for dementia, but if you do have it and you're able to reframe it into like, well, I'm changing, I'm different, but there's still value to my presence. And so often I talk with patients and families about that, like, what is the value of your presence? Like, I think your family would be devastated if you weren't there anymore. And what do you think? What's your family think? And so it's nice for patients to get reassurance that they do still have meaning in the midst of a meaningless disease. So that's something that I think is important for depression. And then knowing that people are meaningful to other people, like with the social engagement, getting involved in senior center activities or a day program, depending on the level of dementia, exercising. Those are the main things that I recommend, or just staying mentally engaged, finding new ways to enjoy hobbies. Like you might not be able to read novels anymore, but can you go watch interesting movies and getting in those ways? So I focus on a lot of reframing and trying to help families and patients come together to solve problems. But I will also add one thing, and that is that sometimes patients with dementia are okay. Just the way that I talked about, like the biology in the brain, and when cells in the brain are dying, and the brain is operating in a different way, and it's seeing the world through a different lens. And whereas, before it seems like somebody was very active and enjoyed a lot of hobbies, and now they might like to sit and watch TV, to other people, that person might appear very depressed or apathetic, but to that person they might be like, well, I enjoy this now, like I enjoy watching TV, and that might be another way to transform enjoyment, transform hobbies through the course of an illness.
Wonderful. Thank you so much for sharing all of this with us today, Dr. Johnson, and thank you for being able to jump on and answer some of our questions. We really appreciate your time. Thank you.
Yeah.